topic of industry and virtual classroom is medulloblastoma. So we have our eminent panelists, Dr. Rupesh and Dr. Devnarayan Datta. Dr. Rupesh is the Director of Neurosurgery, MGM Healthcare Chennai, and Dr. Devnarayan Datta is a radiation oncologist. So we'll have, as per the previous module, we'll have a first talk followed by two case discussion, and then followed by another talk. So I request the panelist will be for discussion at the case for the case discussion for giving expert opinion. So I will request the first speaker to start the talk.
Dr. Nufina?
Dr. Nufina, please.
Yes, sir. Am I audible? Let me share the.
Yes, you're audible. Please go ahead.
Okay. I am unable to share.
Do you have the access?
I'm just. It says I have to quit and reopen. Just give me a minute so that I can.
Okay, madam. Okay, yes.
Sorry.
Dr. Ranjit has joined, but he has some issues with his audio. So that's what he just messaged us.
Yeah. Is there any problem?
I think she has quit and she's going to rejoin, I think.
Because I think for this technical, we already are late by 15 minutes. Yeah.
Yes,
madam. You go ahead.
Yeah.
Okay. So this is a 10 to 15 minutes talk followed by two case discussion and again a 15 minutes talk. Please go ahead. We'll try to stick to time so that we'll do justice to all the topics.
Okay.
Please go ahead, Dr. Nufina.
Yes. So, okay. Yes. So, good evening, everyone. Am I audible now?
Please go ahead. Yes, you are.
Yes. Yeah. Okay. Fine. So, first and foremost, I would like to thank the office bearers of Indian Society for Pediatric Neurosurgery for giving me this opportunity to present to this forum. So, without further ado, let me dive into the pathology and classification of medulloblastoma. Medulloblastoma was described as mid-cerebellar glioma, was coined the terminology of spongioblastoma cerebelli by Percival Bailey. And then they found or rather hypothesized that the primitive cell in the ependyma of the fourth ventricle, they had termed the primitive undifferentiated cell as the medulloblast, and hence they gave the terminology of medulloblastoma to these group of tumors in the intracranial tumors, which was published in 1950. And following that, with the Blue Books of WHO being published from the late 1970s and 80s, these group of tumors were classified under the embryonal tumors with variants like desmoplastic medulloblastoma, and over the years, other morphological patterns like large cell medulloblastoma, anaplastic medulloblastoma with extensive nodularity were also included as variants based on their distinct clinical and biological features. The myogenic and melanotic differentiation were grouped as patterns under the medulloblastoma category. In 2014, Harlem Consensus Guidelines were laid out for the CNS tumor classification, wherein molecular information was required to be integrated into the tissue diagnosis for a histopathology report format. So it became a histomolecular reporting with the 2016 WHO classification categorizing medulloblastomas as genetically defined and histologically defined. Following which we had the C-Impact Now Consortium and the many advances in omics, the proteomics, the transcriptomics, and the publication of DNA methylation-based classification, wherein in WHO 2021 5th edition, we have the current embryonal tumor classification showing the medulloblastoma as molecularly defined and histologically defined. The histological morphologies, the major groups, were included under one tumor type called as histologically defined medulloblastoma. So the WHO laid out essential and desirable diagnostic criteria for each. The molecular definition for medulloblastoma corresponded to the pathway of activation and the aligned DNA methylation profile. While the classic medulloblastoma is the one which has no desmoplasia or nodularity and shows absence of severe anaplasia and large cell cytology with retained nuclear INI1 expression. So these are the time-tested histological morphologies of medulloblastoma, the classic blue round cell small tumor with the homerite rosettes in the classic MB and desmoplastic nodular showing the pale neurocytic islands with the internodular regions showing desmoplasia highlighted by reticulate. The extensive nodularity subtype where you have these expanded lobular networks inside which you see these mature neurocytes in streaming pattern and a thinned out internodular region. And then we have the large cell anaplastic due to its size and the prominent nucleoli with anaplasia in the form of pleomorphism, bizarre features, increased mitosis, apoptosis with cell-to-cell wrapping, nuclear molding, and cannibalism. We also have other patterns of differentiation like myogenic here with strap cells, melanotic with melanin brown pigment highlighted by the HMB45 cells, staining, ganglionic cells or neurocytic differentiation, and the classic biphasic, which is a close mimicker for the desmoplastic nodular type. The significant difference is in the retic stain where you don't find these black reticulent fibers of desmoplasia in between the nodules. The molecular definition of medulloblastoma proved to be the result of many studies from the early 2000s, which then put together an international consensus was laid out in Boston in 2010, defining the 4 main groups or the subgroups of medulloblastoma then by transcriptomic and methylomic profiling, also indicating that all these subgroups or the molecular types have different cells of origin. The Wnt was from the lower rhombic lip derived mossy fiber neuron. The SHH activated cells had tumors had external granule cell layer progenitors. Group 3 were from the nestin expressing stem cells, and the group 4 from the unipolar brush cells or the glutamate expressing cerebellar nuclei. And all these molecular subgroups also had their corresponding predominance of morphology. Moving on to the mid 2010, 2012, and then 2015-17, saw landmark papers in the genome landscapes of medulloblastoma, with one such paper by Northcott et al. In Nature, published by integrating the methylome or the epigenomic typing with the genomic and the transcriptomic data.
Officially can't sign, that's it.
This revealed that specific subtypes were enriched with driver events and corresponding cytogenetic alterations. Another paper by Schwalb et al. In Lancet also showed a similar classification, with SHH being grouped into the child and infant forms and high-risk, low-risk groups for the groups 3 and 4. Cavalli et al. Also revealed the intertumoral heterogeneity by publishing the 12-15 molecular subgroup of all these medulloblastoma. So taking into consideration all the 3 papers, the WHO found that these subgroups were actually similar to each other, only that the nomenclature was differing. And so they stated that the groups 3 and 4 will be classified as 8 major subgroups and SHH into 4 subgroups. Moving on to the WNT, it accounts for 10% of all cases with children and the adults predominantly, and a cerebellopontine angle location with a dorsal brainstem attachment usually, with an intense contrast enhancement due to the relatively porous blood-brain barrier. The morphology is classic with this rosettes and beta-catenin mutation, which can be seen by the nuclear IHC staining of beta-catenin. It shows a very good prognosis with rare metastasis. SHH, or the sonic hedgehog pathway, is divided into 4 subgroups spanning infants, children, and adults, with the TP53 mutation status accounting for 10 to 15%, portending a poor prognosis with large cell anaplastic morphology, which can be again visualized by IHC as diffuse strong nuclear positivity. And these SHH activated tumors usually in the lateral cerebellar hemisphere, sometimes with a gyriform and grape-like pattern corresponding to its morphology of nodularity, be it desmoplastic nodular or an embed. Groups 3 and 4, the non-WNT non-SHH pathways, together account for 60% of medullos. Group 3 is major for infants and children, rarely adults. Group 4 span all ages with a significant characteristic midline location. The only difference being in the pattern of enhancement and the circumscription of the margins. The morphology is usually classic. The group 3 especially shows a very poor prognosis with increased metastasis at presentation and associated MYC amplification, which in turn corresponds to a large cell anaplastic phenotype. Classic biphasic pattern also occurs in these group of tumors. So the 8 subgroups of this group 3 and 4, the clinical relevance is in the subgrouping 2 and 3, which has very meager less than 50% overall survival with increased metastasis and associated MYC amplification, a large cell anaplastic phenotype, especially in the subtype 2 and subgroup 2 and 3, where you have the infant, children, and relatively lesser adults are also involved. Group 3 also has OTX2 amplification, which can be visualized by IHC. So the clinical relevance of this major grouping and the subgroupings in the medulloblastoma molecular classification is primarily to categorize the patients into the following risk categories, depending on the group, the molecular group, the different subgroups showing presence or absence of metastasis, the genetic alteration like MYC amplification, MYC amplification, or TP53 mutation, and cytogenetic alterations like chromosome 11 loss. The staging can be done by Chang et al. Staging criteria, with M1 showing microscopic metastasis in the CSF sample, M2, M3 in the arachnoid space, subarachnoid spaces of the cranial and spinal respectively, and M4 is extra CNS extension. Now, having said all those, we need molecular surrogates to group all these medullos, and so we have the MRI surrogates catching on to the radiogenomic signatures, relying on the site, the enhancement, the margination of or the circumscription of the tumors. Histopath and IHC wise, we have this panel of beta-catenin, GAP1 and YAP1, where Combination of beta-catenin and YAP1 with a negative GAP1 reveals a Wnt-activated tumor. GAP1, YAP1 positivity will show a SHH tumor, and all three negative for non-Wnt, non-SHH. Genetic counseling is essential for these kind of tumors, especially the Wnt, which has association with APC and catenin B1 in the FAP and CMMRD categories. SHH activated tumors with its patch1 and SUFU mutations associated with Gorlin syndrome or the nevoid basal cell carcinoma syndrome. TP53 germline mutations in the leaf romani, especially SHH pathway has more than 40% germline mutation prevalence, with group 3 and 4 having a very meager prevalence, but with DNA repair gene association. So these mutations can be analyzed in both the tumor as well as the blood samples for germline mutation analysis. So this is a slide just to indicate the novel therapeutics for targeted and immunotherapies in line and on par with the advancements of medulloblastoma, but our country being in the lower middle income region with having our own resource constraints, the Asian Oceanian Society of Neuropathology developed the adapted guidelines adapting diagnostic approaches for practical taxonomy and in resource restrained regions. They conducted a survey, showed that MRI with contrast, immunohistochemical markers, especially routine, and some molecular surrogates were available as opposed to this molecular testing like fish Sanger sequencing. The red means negative, so we don't almost have nil DNA methylation profiling. Some next-gen sequencing is seen. So they divided the institutions present in our country into RL1 through RL5 with basic H&E staining, IHC marker, surrogate IHC, basic fish and Sanger sequencing as molecular studies, RL5 with advanced molecular techniques, and found out that only 10% of the LMICs actually have access and affordability towards advanced molecular testing platforms. And so this is an example for an adult type diffuse glioma guideline just to show the histopathological correlation with clinical and radiological information complemented by basic IHC markers and supported ably by surrogate IHC markers with radiogenomic information like T2 flare mismatch sign being suggestive of IDH mutant astrocytomas, followed by any basic molecular test like fish and Sanger sequencing if required. So this is how we apply the same to medulloblastoma. We have the radiogenomic signatures already involved with the MRI, and then we get the tissue post-surgery, which will be religiously looked into and typed as per the histomorphology with the special stains all along, ruling out any differentials like ATRT, embryonal tumor with multi-layered rosettes, and ependymoma grade 3 or even high-grade glioma, especially in the A group, followed by molecular subgrouping with the IHC panel, along with FISH for example, monosomy 6 in Wnt pathway and MYC amplification in group 3 tumors. It can be complemented by sequencing like TP53 mutations and catenin B1 mutations, which can be seen in this picture. Finally, in accessible and affordable cases, even methylation arrays with copy number variations can be looked into. A few years back, a group from our country showed the cost effectiveness of nanostring assay as well with its own due limitations as alternatives to these molecular techniques. This is basically to give out the risk stratification and the management protocol. So, taking into consideration the clinical data like age, site of the tumor, MRI features, histopathological subtype, you go into the IHC molecular grouping based on the patterns of the beta-catenin, GAP1, YAP1, and the OTX2 staining. If beta-catenin...
They're going to present that time, you see whether they're presenting good. Ranjit sir, the last question.
Sorry?
Sir, Tirunal. And...
No, please continue. I request others to switch off their mics. It's disturbing.
Okay.
Please
So,
continue, Dr. Rufina.
yes. So beta catenin, if it is nuclear positive, it goes under the Wnt pathway activation. If negative, but strong clinical suspicion is present, as in a child with classic medullo with a CP angle tumor, which is homogeneously enhancing, go for FISH, look for monosomy 6. Catenin B1 mutation on Sanger sequencing can be done. This constitutes around 85 to 90% of the Wnt activated tumors, and in the less proportion of 10%, you can do the APC mutation and then come to the diagnosis of Wnt activated medullos. The SHH pathway tumors will have GAB and YAP positivity. Of course, look for the TP53 mutation status by IHC. Usually, these are desmoplastic nodular or MBEN tumors in the cerebellar hemispheric region with intense enhancement. For P53, you need to go for IHC, which is diffuse strong nuclear expression. Label them SHH TP53 mutant. If it is weak and scattered, it may be wild type. Then go for NGS panel if affordable. According to the age, look for infant or children, Patch1 SUFU or SMO mutations, or in adults, you can look for third promoter mutations as well. And then label them as TP53 wild type tumors. If in case P53 is negative, but a strong suspicion for P53 mutant with aggressive behavior is noted in the tumor with large cell anaplastic morphology and a midline location, go for Sanger sequencing, look for TP53 mutation, and then brand them soon. For non-Wnt, non-SHH, all markers negative. OTX2 will be the positive marker for amplification status. This is usually midline with differences in the enhancement and the age group. So if it's a fluffy enhancement in an infant or child, most probably group 3. Weak or minimal enhancing in spanning age groups, most probably group 4. But go for FISH if you look for a non-Wnt, non-SHH, mainly for prognostication. You have to do MIC and MICN amplification, and if affordable, you may go for cytogenetics like isocentric trichromosome and chromosome 11 loss as independent prognostic markers, followed by NGS panel for these mutations. Of course,
Can you summarize? Can you conclude, Dr. Rufina, please?
Yes. This is the last. So methylation profiling will be grouped and subgrouped into 1 to 8 based on this. It can also be used for subgrouping the SHH and Wnt pathway activation, but the mainstay is for genetic testing germline mutation for the Wnt pathway, the TP53, the Patch1 SUFU for Gorlin, and the group BRCA2 for groups 3 and 4. So this is the layered report structure, which I usually give. If it is an SHH activated, you have to write the histopathology, say about the IHC markers, and comment on the genetic testing required. If it is non-Wnt, non-SHH, of course, advice for MIC-MICN amplification and further grouping with advanced molecular platforms if warranted. And this would be the management plan. As you all know, the maximum safe resection followed by staging, more than or equal to 3 years if it's standard risk, and Wnt de-escalation of therapy. If it is very high risk, as in MIC amplified G3 tumors or the SHH TP53 mutant, addition of novel targeted therapeutics could be done. Less than 3 years, radiation is spared with novel targeted therapeutics for the metastatic infantile medullos. I express my gratitude to my alma maters. Thank you.
Thank you, Dr. Rufina. It was very, very good, elaborative. At the same time, you made it very simplistic.
Thank you.
Do you have take the questions at the end, or we'll have?
We'll take the questions at the end. I think, Dr. Rupesh, we are running short. Dr. Rupesh, can you invite the first case presenter and go ahead?
Yeah. So now we are going towards the case presentations. Is Dr. Preetham Dange is there?
Yes, I'm here, sir.
Yeah, please go ahead. Yeah.
Can I share my presentation, sir?
Yeah, Dr. Sumit. Dr. Sumit is there?
Yes, sir.
Dr.
Yes, sir.
Sumit will be discussing. Hello?
Yeah, I'm there. Yes.
Yeah, sure. Fine. Yes, Dr.
Yeah,
Preetham,
the format will be the case presenter will present the case. And after that, the discussant will discuss the options or queries management. Then the panelists will comment on the case. both diagnosis and management, and then take forward. That will be the same for both cases.
Sure. Fine.
Yes, sir. My presentation is visible, sir.
Yes, yes.
Yes, please go ahead. Please go ahead.
Yes, sir. Good evening, everyone. I'm Dr. Preetham from Amrita Institute of Medical Sciences, Kochi. So I would like to thank IndusPN for this opportunity. So today I'll be presenting a case of a 2-month, 20-day-old female child who presented with increasing head size and downward gazing of the eyes with no history of seizure, vomiting, or fever. So perinatally, there were perinatal period was uneventful. She was born of full-term normal delivery with a birth weight of 3.2 kgs. So the head circumference at birth was not available. The parents state that it was normal at birth. So on examination, the child weighed 6 kgs. She was an active infant. Head circumference was 45 centimeters. It was outside third centile for the age, and anterior fontanelle was tense and bulging. Sense setting sign was present, and she was moving all 4 limbs spontaneously. So she was initially evaluated with MRI brain. So this is the T2 weighted image, which is showing a fourth ventricular tumor, which is iso to hyperintense and nodular, and with a well-defined plane between the brainstem is noted. So with supratentorial hydrocephalus. So it is extending almost from the foramen magnum till the aqueduct, and it is difficult to differentiate it from the cerebellar vermis, and it is reaching up to the tentorium. So flare shows the same iso to hyperintense lesion with periventricular lucency. There is no blooming on SWI images. So, and diffusion weighted images and ADC showed diffusion restriction. On contrast imaging, it shows heterogeneous enhancement with nodularity. So it is extensively nodular with heterogeneous enhancement. So, so at this point, should I pause for the discussion, sir? Hello?
Yeah, the other discussant can discuss.
Dr. Sumit?
I'm audible, sir.
Yes.
So this is a 2-month-old female child. The posterior fossa tumor, there's diffusion restriction, so high cellularity. DDs may be, sir, medulloblastoma. 2-month-old child, so can be ATRT also, a typical territory trapper. Can be an ependymoma. Medulloblastoma and ATRT are
So, so between medullo and ATRT in a child with a 2 months old, I think ATRT should be the top in the
ATRT should be high up, yes,
yeah, higher. Yeah, you usually don't see medullos in 2-month-old child. Yeah.
And ATRT also will show some necrosis hemorrhage.
Was the spine screening done?
Yes, sir. The spine screening was done. It was done subsequent to the decompression. So it was not showing any seeding.
Okay. Fine.
Okay, proceed with other Dr. Preetham.
Sir, we considered the same ATRT and medulloblastoma as differentials. Medulloblastoma mainly of the classical grape-like appearance with medulloblastoma with extensive nodularity subtype. So other differential which were less likely, anaplastic ependymoma and choroid plexus were also considered. So in this scenario, I would like to pause at this stage for discussion on the management of hydrocephalus.
Sumit, you want to comment?
Yeah, VP shunt can be done, sir, for
Okay. Yeah. I think the child is presented with all features of hydrocephalus with quite PVL. I think so. Priority should be decompression of the ventricles to reduce the ICP.
yes, sir, and then definitive management can be done at a later stage. First, to take care of the increased ICP.
Generally, how long you wait after the shunt for the primary procedure of the tumor?
Done within 4 to 6 weeks.
Hello? Sorry, your
Yes,
voice
sir.
is feeble.
Audible, sir.
No, we're not able to hear you, doctor.
Sumit, doctor, we're not able to hear you. Yeah.
Am I audible now, sir?
Yes, yes.
Yeah.
Yeah.
Yeah. It should be done ideally as soon as possible, like, but within 1 month.
Okay. Okay. Do you want to wait for 1 month? This is a malignant tumor.
So ideally, as soon as possible.
Ideally, if you can avoid a shunt, then it is good. You can if there is no other contraindication like very low birth weight or very low body weight or anemia, then you can directly take for tumor decompression and use a perioperative EVD. And I would mostly consider in this case they might have done a ETV to keep the CSF pathway open and then go to the tumor. Shunt can be done if you think the patient is not fit to undergo a major surgery immediately and you want to buy time for 2-3 weeks. And there are other logistic reasons where, like in our places, where when you cannot operate immediately, then you have to address the urgent hydrocephalus. You can address that. Otherwise, if you can avoid a shunt, in most institutes, you can avoid a shunt.
Yeah. So this is one other question. If at all you're planning for a shunt, this is a 2-month-old child. What type of shunt you would like to? Sumit, can you suggest?
So ETV can also be an option, as sir suggested, sir.
But this is only a 2-month-old child. So how the ETV? Because generally the ETV success rate is not
High
that
chance of failure. Yes, a high chance of failure.
high chance of failure.
Yeah. Medium pressure shunt, ventriculoperitoneal shunt can be inserted.
Yeah, Dr. Preetham, please go ahead. No.
Yes, sir. So in this case, we went ahead with the endoscopic third ventriculostomy. As sir told, the initial presentation was hydrocephalus, and the child was very young, and there was no. I mean, we did not anticipate that we'll be able to remove the entire tumor at one go because of the size of the lesion and the age of the child. So, following third ventriculostomy, the scans show a slight reduction in the size of the ventricles and a flow void can be noted at the ETV site. So the definitive.
Just a minute. For a query, you see that
Yes, sir.
already the foramen magnum is so crowded. And
Yes, sir.
do you really expect the ETV may work if the CSF really get decongested? Because you see, you are doing to finish it into the prepotent cistern, but then
Yes, sir.
when CSF comes down, you see the foramen magnum is completely crowded. The tumor is
Yes.
filling the space and the posterior fossa is so full. So do you really anticipate or expect the ETV to be successful? To really do the job of decompressing the ventricles
Yes, sir. Probably.
in this scenario?
Um,
Because
yeah,
I seriously doubt whether ETV may really do the justice for this patient.
yes.
Yeah.
Well, but yeah. Considering the age of the child, ETV success
No,
rate
no,
may
not,
be.
not about the age. In this particular case, when foramen
Hmm.
magnum is full of, you see that the foramen, if you see the sagittal image, you see
Yes.
that the foramen magnum is so crowded. And
Yes.
CSF has to get percolated around the cisterns. But then you see the cisterns are all obliterated. So the CSF may not find the path to really get decompressed preoperatively. As you see
Yes.
image. Okay, please go ahead. Yeah. So this is for the discussion purpose.
Yes.
Yeah.
So for the definitive, next we plan for definitive surgery after a week. So for the discussion, I'll pause at this point.
You complete, Dr. Preetham.
Yes,
Complete,
sir.
then we'll discuss.
Yes, sir. So we went ahead and did a midline suboccipital craniotomy and subtotal decompression. So subtotal decompression was done in view of we had crossed the maximum allowable blood loss for the child. So histopathology turned out to be medulloblastoma, desmoplastic nodular type, WHO grade 4. So at this point, we got a spine screening contrast, which did not show leptomeningeal disease. So CSF analysis was also done. There was no malignant cell seen in the CSF. So the clinical risk stratification is the child falls into high risk group because the age of the child is less than 3 and there was a residual tumor which is more than 1.5 square centimeter.
The post-op MRI is there of the tumor posterior fossa?
Yes, sir. Yes, sir. Yes, sir. I'll be coming to that, sir. So molecular subtyping is positive. I'll is a molecular subtyping is a SUFU positive and which falls into SHH category, and TP53 and MIC were negative. MIC amplification were negative, which were poor prognostic factors. So molecular stratification by it will fall into a norm standard risk. So this is the post decompression imaging. So it shows a residual image, residual tumor, sagittal image. So so after a month, the patient was taken up for second stage decompression. It was re-exploration was done and near total decompression was done. So this is the image after the second surgery. So there's some residual disease at the near the tentorium. So following this, the child underwent chemotherapy, the induction chemotherapy of 3 cycles of etoposide and cisplatin, followed by 7 cycles of vincristine and cyclophosphamide. 4 cycles has been completed as of now, and child is going to take the 5th cycle. At present, the child is alert and active. There is slight delay in developmental milestones. Otherwise doing well. So even though it is slightly outside my topic for today, so it had the child had a stomy course with regard to hydrocephalus. Initially, there was a CSF leak following the second surgery for which VP shunt was done, and following which she developed subdural hygroma. Shunt ligation was done, which did not resolve the hygroma. Burholes had to be made to evacuate the hygroma. Then there was increase in head circumference. Finally, a programmable VP shunt was placed.
Yeah. Okay. Thank you.
Dr. Sumit, anything you would have done differently?
Endoscopic third ventriculostomy is she's just a 2 month.
Sumit, you're not audible.
Your voice is very feeble, Dr. Sumit.
Am I audible now, sir?
Yeah.
Yeah. As a child is as she's just a 2-month-old girl, sir, we would have done peritoneal shunt first rather than an endoscopic third ventriculostomy, which has high chance of failure in these cases.
Hello, my name is Ricky. I'm the pediatric oncologist. Can I say
Yes,
a
ma'am.
few things?
Yeah, please. Yeah.
So from a pediatric oncologist's point of view, this any child who you're suspecting is like an MBEN or a medulloblastoma with extensive nodularity, we would actually prefer if you did not put a VP shunt, because treatment, we have found that if we do intraventricular chemotherapy, these children actually do better. So the MBEN or the desmoplastic and the desmoplastic nodular kind of tumors are often SHH, as Dr. Nafina said in the earlier presentation. And these SHH tumors are mainly of two types, SHH1 and SHH2, which comes in infants, that infants being less than 3 years in pediatric neuro-oncology, as you would all know. These children actually have shown to do much better if you give intraventricular therapy, which actually means putting in an Omaya into the ventricle and giving methotrexate there. Now, we will not be able to do that if there is a VP shunt that is going into the peritoneum, because obviously the methotrexate will then collect into the peritoneum, and so this is not possible. If you have no other option but to put it, we would like you to put an adjustable VP shunt, and that would then enable us to close the shunt, give the intraventricular therapy, and then release it again. This is just input from our side, and yeah, I know it's not always easy, but yeah.
Yeah, point well taken, ma'am. Yeah, but I think here, I think they didn't have a choice. They did initially ETV, but then because of the CSF leak and the high pressure, I think they were forced to sort of do the VP shunt. Yeah.
Thank you.
Thank you. But one suggestion is that you had done a programmable VP shunt. Probably now there are the new programmable VP shunt. We can like sort of switch off the shunts. So probably it's like it can be like a non-existing shunt for some time, wherein the intraventricular chemotherapy can given through an Omaya, and then probably we can on the shunt after the probably 24 or 48 hours later. We have the option now available where we can switch off the VP shunt, where the CSF may not drain into the peritoneum.
Okay, sir.
Yeah, I think there is a question from the chat box. Dr. Vishal Verma has asked, are there any predictive factors for need for permanent CSF diversion? And when is ETV preferred over VP shunt?
I think that there is a Canadian scale now, which will tell who are the patients who will need a VP shunt. And but this particular case is quite challenging because it's a 2-month-old child, very large tumor, very significant hydrocephalus, and as you see, the blood loss is a major issue. So at one go, they couldn't remove the tumor completely. They had to do a stage, which is very accepted now. And I think ultimately the tumor could be removed maximum safely. ETV, very less than 6 months, the chance of success rate is quite low, especially with the tumor blocking, compressing the fourth ventricular outlet like this. It's quite not work. So I think this particular child probably, instead of doing an ETV, first instance should have done a VP shunt, And probably they consider after the tumor excision, remove the VP shunt if possible, if they feel that the tumor fourth ventricle has been re-established. That could have been also be possible.
Yeah, there are
Okay.
papers. I mean, we're running short. I'll just close it with this. There are papers. I think one paper is there from CMC Vellore itself, where they've shown if there's a post-op bleed, post-op hematoma, or a post-op blood in the ventricles, that increases the risk need for CSF diversion. And there are many papers. There's no single straightforward answer. There's one more comment in the query in the uh, question in the chat box. Any thoughts on adjuvant chemotherapy after the first decompression, further downstage, and then go for second stage excision? That is possible. In fact, I have some patients where there's a very large tumor, posterior fossa medulloblastoma, and we thought even decompression will be very challenging. We had just taken biopsy. Patient underwent chemotherapy after 2-3 months, good response. Once the tumor shrinks, child grows and has a better anesthesia risk, then we had gone ahead and operated. I think we'll close with this. We'll go to the next case. Thank you, Dr. Preetham.
Thank you, sir.
We are at 8 o'clock.
Yes, sir. I'll stop sharing.
Yeah.
Thank you, sir.
Dr. Sumit, you are ready?
Yeah, am I audible, sir?
Yeah, please go
Yeah,
ahead.
please go ahead. We'll go straight for the case. 15-20 minutes so that the last speaker will have the time.
Hello. So I'm presenting the second case. I am
So please increase your volume. Your voice is feeble. I think we have to come a little closer to the mic.
Am I audible clearly now, sir? I've increased the volume.
You better not clearly, but please go ahead.
Yeah. I'm presenting the second case. I'm Sumit Malgaonkar. I'm a second year neurosurgery resident of Sri Chitra Tirunal Institute for Medical Sciences and Technology. Hello, sir.
Go ahead, please. We are able to hear you. Go ahead.
Okay. Yeah. So this was a 4-year-old male child, sir. He had already undergone a midline suboccipital craniotomy at an outside center for a posterior fossa lesion in October 2024. And the post-operative histopathology there was suggestive of an embryonal tumor, likely medulloblastoma. But the early post-operative scan had shown significant residual tumor in the fourth ventricle and vermis. So he was referred to our center. So then he presented to us with 1 month history of this progressive cranial headache, recurrent vomiting episodes, lethargy, and gait instability. On examination, he was alert with stable vitals. Neurologically, he had papilledema, truncal and gait ataxia, mild limb dysmetria, and motor power was more than 3/5 in all the limbs. And he did not have any cranial nerve deficits, and sensory examination was normal. So the overall clinical picture suggested raised intracranial pressure and cerebellar dysfunction secondary to a residual fourth ventricular tumor causing obstructive hydrocephalus. So this was the first pre-op CT, which was done before any surgery. So it's showing there's a hyperdense midline posterior fossa lesion centered in the region of the fourth ventricle and vermis. And this mass, it has completely effaced the fourth ventricle, and it has produced significant obstructive hydrocephalus with upstream hydrocephalus, and there's some periventricular lucency also. And in this, the brainstem also seems compressed. And so these findings are typical of a midline posterior fossa tumor in the side, most commonly a medulloblastoma. And so this was a preoperative MRI. It shows there's a midline posterior fossa mass.
Others, please mute yourself. Please mute.
Can I continue, sir?
Yeah, please continue.
Yeah. So this pre-op MRI, you see there's a midline posterior fossa mass arising from the vermis, and it is completely filling the fourth ventricle. And on T1 sequence, it is iso to hypointense, and on T2 and flare, it was heterogeneously hyperintense. And the lesion showed restricted diffusion, which is like typical for highly cellular tumor like medulloblastoma. And the post-contrast sequences also showed some heterogeneous contrast enhancement and a significant mass effect with some displacement of the brainstem and the fourth ventricular aqueduct were effaced and resulting in upstream hydrocephalus. And so this preoperative MRI, like this also imaging features are strongly in favor of a medulloblastoma arising from the so in this post-operative MRI, this surgery was done outside. You can see it showed a large residual tumor still filling the fourth ventricle, and the mass was T1 hyperintense on T2 and flare, and there was restricted diffusion. And post-contrast images showed heterogeneous nodular enhancement, and aqueduct in fourth ventricle's outlets remained obstructed, and the child continued to have significant hydrocephalus. So this findings were suggestive of an incomplete tumor excision, and for this was the basis for planning for a re-exploration at our center. So we performed a re-exploratory posterior surgery through endovelar tonsillar approach. We opened the previous incision and we removed a C1 arch and a Y-shaped urotomy was done, and we inserted a right phases VVD to drain the and then we opened the cerebromedullary fissure. The tonsils entered the fourth ventricle. The tumor in this case it was fleshy, vascular, and it occupied the entire fourth ventricle and it extended into the lateral viscera also. And the planes were very poor with the brainstem. And in this case, the frozen section showed an embryonal tumor. So internal debulking was done using suction in CUSA, and it was carefully dissected of the brainstem, and we were able to do gross total decompression. And we also noted CSF flow at the end of the procedure, and we closed it with a pericranial patch, and subsequently the patient was shifted to ICU with EVD in place. So just coming to the advantages of the approach which we took. So this is several advantages. The most important is that the vermis is not split like the classical transforming approach. So it significantly lowers the risk of post-operative cerebellar mutism, which is more commonly seen in transforming approaches. And also this approach uses a natural corridor through the cerebromedullary fissure. So there is very little cerebellar retraction, and the normal tissue planes are preserved. And there's direct exposure of the fourth ventricle, including the floor also. And we can see the foramen of Magendie and even the aqueduct. And functionally also, the patients tend to do better because we avoid unnecessary injury to the vermis and deep cerebellar nuclei. And the post-operatively also ataxia and cranial deficits are less. So this is actually a versatile and a very good approach for posterior fossa lesions.
Dr. Sumit, I think you should go to the point of discussion.
Hello, sir. Hello, sir.
Yeah, please go ahead, please. I'm just telling you can be brief on this, and you can go to the discussion points in this case, so that.
So this was a post-operative CT, sir. Hello, sir.
Please continue. Please continue. Yeah.
In this post-operative CT, you can see the fourth ventricle looks adequately decompressed, and then the ventricular system it remained mild to moderately enlarged, which is like expected in the post-operative period. And there's an EVD also which you place. It is correctly positioned, and there's no post-operative hematoma, no infarction, and overall the immediate post-operative CT showed adequate decompression. With satisfactory positioning of the EVD, and there were no acute complications. This patient had two significant post-operative complications. Cerebral mutism happened. So can I ask, like, why even using the tilovelar tonsillar approach, the cerebral mutism happened in this case? Like, this was a point of discussion.
No, you want to finish and we can discuss, or you have some more slides?
No, I have few more slides, sir.
Yeah,
Could I
please
finish?
finish that. You finish that, then we'll have go ahead.
Complete it.
Okay. So in this case, the cerebral mutism, it developed around day 2 and 3. Then subsequently, the child was able to speak well. Child was active, alert. He followed commands, but there was difficulty initiating speech. So this is characteristically seen in these cases in midline posterior fossa tumors, especially when the Vermean region is involved. And the second issue in this case was persistent hydrocephalus. Even when the posterior fossa was adequately decompressed, the ventricles, they remained enlarged, and the child even had then intermittent lethargy and reduced activity. And patient, we subsequently had to do a VP shunt for this patient, and that VP shunt got blocked, and then we had to subsequently revise it again. So this was the last scan done after the shunt revision. It's showing a well-positioned right phrasius VP shunt, the catheter tip in the frontal horn, and there's no hemorrhage. And the ventricular system in this, you can see it is significantly reduced in size compared to the pre-revision scan. And there were, you can see again, there is minimal bifrontal hygroma, which are expected after shunt insertion. But the posterior fossa cavity was stable, no evidence of post-operative hemorrhage or tumor recurrence, and overall it showed a functioning shunt and there's a good post-operative radiological outcome in this case. So I just briefly wanted to go talk regarding cerebral.
No, please go ahead. Please go ahead. We'll have more discussion. What is the pathology report and what was done for the patient? Yeah, please go ahead with that. Yeah.
I'll briefly talk. So yeah.
No, this. Go ahead.
Yeah. This is also called post-operative cerebral mutism syndrome, and the reported incidence in literature is roughly between 10 to 13%, and it is predominantly seen in children with midline tumors, especially Vermean medulloblastomas, and it presents around day 2 and 3, of surgery, and the strongest risk factor for this is the tumor in midline location. And when there is involvement of the dentate nucleus, there's severe traction and retraction of the superior cerebral peduncles. And the understanding is that it results from disruption of the dentato-thalamocortical pathway. And the speech in this case usually returns over days to weeks. Although many patients, they have some dysarthria, and management is mostly supportive. And early speech therapy, physiotherapy, and neuropsychological rehabilitation should be done in these cases. And so coming to the HPR report of in our case, it showed a classic medulloblastoma, WHO grade 4, and microscopically, as you can see, a tumor infiltrated the cerebral folia and was composed of small to round to ovoid cells, and there was no desmoplastic or nodular pattern seen. And immunohistochemistry showed a synoptophynin positivity and INI1 retention, which is characteristic of medulloblastomas. This is absent in ATRTs. And there's patchy GAP1 and filamin A staining, and so based on the morphology and ISC, the tumor fits best with classical medulloblastomas. And in this case, adjuvant therapy was initiated immediately after post-operative recovery. And as a child was more than 4 years, we gave a full dose of craniospinal irradiation, around 36 grays to the craniospinal axis, and also posterior fossa tumor boost was given. And so after completing radiotherapy, he was started on systemic chemotherapy, like cisplatin, vincristine, and cyclophosphamide are going on. And currently the patient is active, alert. He is doing well currently, and he's planned for a follow-up in the subsequent month.
Okay. Dr. Preetham, you want to discuss about this case?
Yes, I would like to ask what was the I mean, if the spine screening was done to see the leptomeningeal disease before.
Yes, a spine screening was done. It was there's no deposits in the spine.
Okay. Okay. What do you think the molecular group will be in this case with all the available pathology, the imaging characteristics? What do you think it could be?
It could be SHH,
Yes,
in which the classical and nodular variants are more common.
it was not nodular. It was not nodular.
Sorry.
It was not much enhancing. It was coming down to the fourth ventricle, down foramen magnum. So
Yes,
both
sorry. WNT is probably more.
both YAP negative and this one is both were negative. So I think it could be falling into the group 4 category, at least for the imaging wise, putting all together. Possibly it's a group 4 medullo, molecular wise.
Yeah, Dr. Nufina is there. She can comment. You can show the IHC slide. See, WINT and SHH has got surrogate markers in IHC. When both are not there, then it becomes it's either a group 3 or 4. That's why they have finally concluded that it will require a transcriptomic profiling or you have to do CMYC, NMYC amplification. Dr. Nufina, do you want to comment?
Yes, sir. In this
See, this beta catenin is absent, YAP is negative. They have done.
GAB1 shows patchy weak positivity.
Yeah.
So with YAP1 negativity and GAB1 showing patchy weak positivity, probably it does not come under the IHC profiling. So that is
That's
why,
what.
yeah, that is why the subtyping
So
could
you cannot conclusively say it is WINT or SHH.
non-Wnt. No, it is not SHH or Wnt by this
That's
because
what it is.
GAB1 should be
It
negative.
is.
GAB1
Yeah,
should
it
be
is
positive.
non-WINT, non-SHH group.
Yes,
It is.
it may be non-Wnt, non-SHH, but since patchy weak positivity of GAB1 is there, it does not actually fit it into the algorithm. So that is why the grouping could not be given by IHC in this case.
Yeah.
Okay.
So yeah, correct. But putting to the imaging characteristics, usually group 3 you will have a little bit more of a fluffy, irregular margin, and the enhancement was also not very great. The tumor coming down till the foramen magnum. So putting all features, it could be a group 4 medullo. My question is to the pediatric oncologist. This particular case, they had given concurrent chemotherapy. So generally, concurrent is given for a group 3 medullo, and group 4 they give adjuvant. So what is your take on this, madam? We had a pediatric oncologist who joined for the last case.
Sorry, yes, I'm here. Sorry, can you just tell me
Yeah,
your
yeah, yes,
question
madam.
again?
Yes, yes. So generally, if this case they had considered a concurrent chemo along with radiation, generally it is done for a group 3 medullo. So what it is also done for group 4 medullo, or it is there are what are the deciding factors where you give concurrent chemo and radiation therapy in a medullo?
So it depends on what protocol you're following. What we are doing here, so it will be given for the high risk children, the children who will fall into high risk category. This child actually would still be intermediate, would be in the standard risk only. Yeah, so what we are currently in CMC, we are not using anything concurrent actually. So we are for the high risk patients, we straight away go and we give them higher doses of chemotherapy. We use a St. Jude's protocol. Yeah.
Because this child, I think they have removed a gross total excision. There is no obvious residue, and doesn't fit into. There is no metastasis. Spine screening is okay.
Yes.
And the child had mutism also post. So I feel probably they should have given radiation and then considered chemo as an adjuvant. Maybe institute-based protocol.
The other thing is this group 3, group 4 is not something we can easily differentiate. We have only WINT, SHH, and then it's group 3, group 4 is clubbed as one, right? So if you're going to say only for one, it doesn't really work.
Okay.
Although group 3.
So My other question is with the child with mutism, so the performance score a little comes down, and so how risky is the concurrent chemotherapy in those children vis-a-vis children who are relatively doing well after surgery?
Oh, we continue with the radiation and chemotherapy. It doesn't, I mean, that is the only chance they have. So we
Okay.
need to do it.
Fine.
It doesn't stop us from going ahead with the chemotherapy.
Okay.
And like you said, by the time that 6 weeks of our radiation therapy have finished, they kind of improve as well. And by the time we start the chemotherapy, they're a little bit in a better space.
Okay.
Just wanted to, Dr. Sumit's point, what you're saying, regarding mutism. Though the mutism is one of the many forms of manifestation of this condition. It's now no more than cerebellar mutism. It is now called posterior fossa syndrome. Of that, one of that is mutism. There can be so many other cognitive changes, and you said it will come in 2 to 3 days, and it can go by some days to weeks. But this posterior fossa syndrome symptoms can be present for months to years, and these children will require long-standing and regular support and training, both in cognition as well as in psychosocial care, so that they can improve. So we should remember that mutism is one part, but it is not the only part in this condition.
I agree that also that a lot of times we think it is a transient thing and it all improves. Yes, it does. Almost everybody will have some improvement, but it may not be 100% back to what they were in originally.
And
So
there are a lot of studies also that children who develop mutism are never like absolutely normal. They have significant follow-up shows cognitive dysfunction in them.
yes.
Yeah. And for some reason, it happens only in medullo. It doesn't happen in ependymoma or other middle and posterior fossa tumors. Somehow, something is related, something peculiar to only medulloblastoma. So, yeah,
Reported in others as well, hasn't it? Anyway, but it's mostly with medullo that we know.
The other complication that this patient had, or rather other challenge this patient had, is the need for a shunt. So the need for shunt is like, I think one of the comment has come like 30%. The need for shunt can be pre-op, immediate post-op, or delayed post-op. That depends on whether the CSF pathways get opened or not. Like I said before, if there is a bleed and adhesions, even if you remove the tumor completely, the CSF pathways may not be opened. Then, if there is a persistent hydrocephalus, it's better to do shunt or better to do any CSF diversion to reduce the pressure than just keep on watching, because it will affect the treatment. It will affect the wound healing. If there is a CSF leak, it will delay the further treatment. So it needs to be addressed whenever it is identified. I think these are the two complications that were highlighted in this case. I think I'm not seeing any new comments in the chat box. We can go to the last talk now. Thanks, Dr. Sumit and Dr. Preetham.
Thank you, sir.
Dr. Vishaka,
Yes, sir.
yeah, can you please give your talk?
Yes, sir. Excuse me, is it visible, sir?
Yeah, please go ahead. Yeah.
Yeah, some of the topics have been already discussed, but I'll just try to be brief about my topic. So I'm going to discuss mainly early complications of medulloblastoma surgery and a little bit brush up about the adjuvant therapies. So this has already been discussed. So even in Indian studies have shown that it is one of the most common posterior fossa tumors, which accounts for almost 28 to 40% of the tumors in the children. And why medulloblastoma has more potential for severe complication is because of its proximity to the critical structures which are on the fourth ventricular floor, and like cranial nerve nuclei, long tracts, respiratory vasomotor centers, and cerebellar and vermis. So So when we see incidence, approximately 30 to 62% of the children have some form of complication. And so for the best outcome, when we talk about the outcomes, so we actually talk about not only just the length of the survival, but we also talk about quality of survival. So quality of survival basically compromise the level of disability and discomfort. And this usually comes with maybe because of tumor itself, surgery, or adjunct treatment. So now we are looking at the how to reduce the surgical complications so that the outcomes can be better. So for this, we have to first identify the predisposing risk factors, then identify the etiologic mechanisms, and then implement the methods to mitigate these risks. So what are the when we call it, like, what is surgical complication is basically an unwanted event, problem, or any clinical syndrome which comprises of cluster of signs and symptoms. This this can occur because of surgery. So there might be new complications which can occur because of surgery, or there might be aggravation of the pre-existing deficits. Complications could be because of general anesthesia, or few pathological mechanisms also can give rise. So just to list, I have divided the complications into neurological, like posterior fossa syndrome, dysphasias, dysarthrias, limb and facial weakness, etc. Regional are basically wound-related CSF, like CSF leak, pseudomeningocele, hydrocephalus progression, or intracranial hemorrhage or infection, or infection, etc. Then coming to systemic, because these surgeries are quite long-standing surgeries, and there may be a lot of blood proximity to the fourth ventricular floor, and the blood loss also can give rise to hemodynamic instability. Then other systemic infections because of the prolonged ICU stay, systemic infections in DVT. Sometimes we might have to do some intervention for the complication itself. So for example, for hydrocephalus or hematoma, we might have to take the patient again into the OT, or sometimes unplanned admission to intensive care units also might be there because of respiratory issues, and then prolonged intubation, or some complications might be because of the large volume blood transfusion. So coming to the potential pathological mechanisms by which neurological complications occur. So basically the pathological mechanisms like raised ICT or systemic hemodynamic instability can cause global cerebral ischemic injury. The local injuries can be caused because of retraction, or focal ischemic or contusion injury when we are operating because of retraction, edema, or vasospasm. Then direct tumor-related focal injury can occur because of invasion or hemorrhage, or direct local injury by surgery can occur because of neurotemesis or nerve damage. Sometimes even remote injuries are possible because of transsynaptic degeneration. So we will see later what are these neurological complications. So now coming to, as I said, we have to first see what are the predisposing factors to reduce the complications. So there are many factors, like baseline factors with presenting deficits, the already existing hydrocephalus, or young age, demographic factors like age, then intraoperative factors like surgical route, or perioperative factors like CSF diversion, or tumor-related factors sometimes because of the vascular or large tumor, or the location of the tumor. So why it is important to know the risk factors, because we can counsel the parents according to that, and if there are some modifiable factors, we can modify it. So now we will just see, so what are the risk factors and how they can cause the complications. So for example, age, in young age we can see there is increased risk of hydrocephalus and CSF leak. And if there is hydrocephalus, pre-existing hydrocephalus, it can increase CSF leak, raised ICT, and associated issues. Then if the tumor is delayed diagnosis, there is late diagnosis, then we can expect invasion and extension of tumor or hydrocephalus. So here there's one point, because here Even if the tumor is lately diagnosed, patient may not have more deficits, but surgery can cause a lot of deficit, even because here the tumor is there since some time, and that is why there might be some plastic alterations which occur in the surrounding brain. But surgery will be an acute injury, so that is why the deficits will be more. Now, coming to the factors which are related to tumor location, size, or extension. So, if the tumor is midline or attached to the fourth ventricle, then chances of posterior fossa tumor syndrome, cerebellar mutism, hydrocephalus, progression, ataxia, etc. are more. If it is cerebellar, definitely the appendicular ataxia and has more, can occur more. Then, if the peduncle is involved, then it carries increased risk of ataxia and also posterior fossa syndrome. If it is extending into the CPA angle, then a lot of cranial nerve palsies we can see. And similarly, if there is brain stem infiltration, we can see bulbar palsy, or we can have patient can have obstructive central apneas, and we can expect the prolonged ventilatory support, need of prolonged ventilatory support, and sometimes the weakness in the limbs. Next is, according to the tumor characteristics, also the complications occur. If the tumors are very vascular, then there's a more risk of hemorrhage and hematoma. Or if the tumor is very big, then because of the retraction, there might be a lot of injuries. The last one is surgical approach. So, as we know that CSF leaks or sodium seal are more common in posterior fossa surgeries, but the CSF leak rate may be higher with the craniectomy than craniotomy. Then coming to extent of resection. So sometimes the intent of gross or near total resection in infiltrated tumors can cause more neurological sequelae. Then surgical approach, how can it increase the complications, is because if we are using a vermian split incision, it increases the risk of posterior fossa tumor. Or if we are retracting more, that also increases more complications. And sometimes the early adjuvant therapies can cause more skin issues. Now coming to the practical approach. So we will see how day-wise complications and how to prevent it and how to detect it early. Sorry. So this is a list of complications which can occur in day 1 or 2. So the first is acute posterior fossa hematoma. The child especially present with sudden fall in GCS, new brainstem signs will be there, anisocoria, signs of raised ICP. And this can occur because of postoperative arterial venous bleeding into the tight posterior fossa, and that causes rapid mass effect. So the potential risk factors here are vascular tumors, tumor encasing the vessels, or sometimes because of a lot of blood transfusion, there might be massive blood loss and transfusion. There might be consumption coagulopathy leading to more risk of bleeding. So we have to prevent this, we have to achieve meticulous tumor bed hemostasis, and we have to maintain the blood pressure. And if the hematomas are large enough, causing a lot of mass effect, we have to surgically evacuate it. The next is acute hydrocephalus. So sometimes even the presentation can be again similar. The patient may not get up from the or may not wean off from the ventilator, or if the patient has already extubated, then child can have headache, vomiting, irritability, or signs of raised ICP again. And this can occur because this is an acute phase. So initial 1 or 2 days, there might be still blood or residual tumor, sometimes obstructing the fourth ventricle, obstructing the aqueduct. And that is why it can cause hydrocephalus. So here we have to evaluate with imaging, but we have to make sure that if the child is conscious, or if the child's consciousness is deteriorating. If deteriorating, then make sure that intubate the child and then do imaging. And here, if the hydrocephalus is mild, anti-edema measures we can give and watch. But if it is progressive, then we can try temporary CSF diversion here, because it is because of the blood or edema can subside, and later on we can decide about the permanent CSF diversion. The next complications are sometimes the child, once if child is extubated, sometimes there might be dysphagia or dysarthria we can see, or facial weakness, gaze palsies. So these all could be, or weak gag or cough reflex. So more chance of aspirations will be there. So this can be because of brainstem cranial nerve injuries, and can be because of this occurs mainly because of direct surgical trauma or traction when we are working around the fourth ventricular floor. So this is common in occurs in around 30 to 33%. Dysarthria often follows a period of cerebral mutism.
Madam, please go ahead. Others, can you please mute yourself? Madam, please go ahead.
Yes, sir. So here, the presence of dysphagia prior to surgery. One point is presence of dysphagia prior to surgery is a definitive predictor for worsening of dysphagia after surgery. So the next is new motor deficit. So the child has weaned off, and then we can see there is new hemiparesis or limb weakness or facial weakness, asymmetric movements we can find. And this could be because of, because it is just first or second post-operative, could be because of edema or sometimes injury to the injury or infarct of the cerebral peduncles or brainstem tracts. So if it is because of edema, it will improve over a period of time. But if it remains permanent, then we can then there is a permanent injury. Sorry. So now coming to systemic instability, then as I already mentioned, hypotension, hypotension, tachycardia, or some changes in the vitals we can expect because because the fourth ventricular floor, like we will dissect near that, so we can expect those issues. And then some metabolic issues also we can expect because of the prolonged surgeries. And the other common, like not common, but it is a important complication is sometimes the child may not wake up from the when child goes into prolonged unresponsive state, or and then this can cause failure of planned extubation. Or sometimes the child can start having altered behavior such as agitation, aggression, or withdrawal. So this can indicate the starting of posterior fossa syndrome. So now coming to the next set of complications, which from day 3 to day 14. So here persistent motor deficits can occur, persistent cranial nerve deficits can occur. So if they are persisting, then we are sure that some injury has happened, and we have to do physiotherapy, and we have to assess the need of gastrostomy or tracheostomy. Next is posterior fossa syndrome. I'll go in detail about this. So this is basically acute neurobehavioral syndrome with deficits in speech, not only speech, but affect and volitional behavior. So what are the alterations in behavior are? There will be labile affect, reduced social interaction, and avolition. What is avolition is there is lack of motivated goal-directed volunteer behavior, but the automatic behavior such as yawning, they will be preserved. And along with these symptoms, other symptoms like even ataxia, dysphagia, apraxia, or oromotor dyskinesias can occur. And why does this occur is because along with the dentothalamic tract, the structures which are present nearby to that tract also will be involved. So this is the reason for this. Next is, and it occurs approximately 24 to 29% of cases. And the incidence is increasing maybe because we are more aiming for near total excision, and that is why we maybe there is increased injury because of the retraction. So most of the patients who have posterior fossa syndrome, the symptoms start within 100% patients, symptoms start within 1 week, and in around 50% within after 2 days of surgery. It doesn't start immediately, and as already discussed, it can stay up to weeks or months. And then here the important point is initially for initial few days we have we have to exclude few conditions which might mimic posterior fossa syndrome, like because obtundation because of hydrocephalus progression or meningitis, etc. So what is the mechanism is, we all know that this is a dentatorubrothalamic tract, which the basic substrates are dentate nucleus, superior cerebellar peduncle, and where it decussates, it goes into the red nucleus, and then thalamus, and then frontal and temporal lobes. So this is a DTI picture in normal cases, and here in the patient who has a tumor. So you can see here. So because of the dissection near the peduncles, the efferent cerebellar pathways will be damaged, and this causes cerebello-cerebral diakinesis. So what does it mean is there will be disruption of the fibers there, and that is why basically the impulses will not go to the cortex, and the reason here, the reason of neurobehavioral problem is basically because there is a disconnection over here. The symptoms which will mimic as that of lesions of the frontal and temporal lobe because of the disconnection. And some studies also, they have, it is seen that there is some hypometabolism after this in patients with posterior fossa syndrome in these regions, frontal and temporal lobes. Sorry. So this is the study which shows that there is a hypofunction following the cerebellar surgery in these areas. So what are the other proposed mechanisms of injury which can cause not just the direct, but then surgical edema related injury, then delayed vasospasm or metabolic insult from abnormal neurotransmitter release, or microstructural axonal injury during surgery. Or sometimes even the rapid stress and strain in the process of removal of the tumor also can cause some injury to these fibers. Sorry. So what are the risk factors? So if we see the subtypes, it is more common in the G3 and Wnt population, Wnt subgroups. And other risk factors are midline tumors, dentate involvement, large tumors, brainstem invasion, then progression of hydrocephalus, and young age, and tumor more than 5 centimeters. Sorry. So the role of surgical factors in posterior fossa syndrome. So the resection and length of incision of the vermis. So initially, Pollack et al. Has suggested that the vermian slitting approach can increase the risk of posterior fossa syndrome, but it is not only the cause of that, because even when we started adopting telovilla approach, definitely the frequency has reduced, but it is not completely gone. So what are the other possible surgical factors are, because the larger tumors require more retraction and cause concussive injury of sensitive structures like these dentate nucleus and peduncles, and which already are compromised and already are distorted because of the tumor. So how can we prevent this? So first is, as we all know, adopt telovilla approach, avoid splitting of vermis, but at the same time avoid CUSA bipolar on the lateral walls of fourth ventricle directly, and avoid retraction related injury. So long-term outcome, just now even Dr. Rupesh sir has also told that these patients, even they recover, they have long-term issues like long-term cognitive issues and long-term reading difficulties, etc. The next complication is persistent or established hydrocephalus. So the progression of hydrocephalus can occur in around 10 to 62% of patients, mostly in early post-op, rarely after 30 days. And the specific risk factors are young age group and midline tumors have more risk of hydrocephalus. So as there was a discussion going on, like which patients or what is the treatment protocol. So here the Canadian preoperative prediction rule for hydrocephalus. So they have given a score which includes the age, presence of papilloedema, which was initially there, but they have later replaced with the transependal edema, or the moderate or severe hydrocephalus and cerebral metastasis as the predictors, and pre-op estimated tumor diagnosis, whether it is medullo or epinema or brainstem glioma. So these are the score, and when the score is more than 5, then it carries high risk of hydrocephalus progression. So there, according to that, we can decide the management of hydrocephalus, whether to do a temporary CSF diversion or a permanent one. Now, this was also the point of discussion, that what is whether ETV or VP shunt is better. So there are many studies which shows that it is controversial. Tamburini et al. In 2008 they have told that ETV is better, but again Kulkarni et al. Had told that the outcomes and the quality of life is better when the ventricular size is smaller. So they were proponent of VP shunt, and again the Kulkarni et al. Has again studied the quality of life in both ETV and VP shunt children, and they found it as there was no substantial difference. So again, this is controversial. Now, next is CSF leak or pseudomeningocele. So this we can see a swelling which occurs at the surgical site, and this can occur because of non-watertight dural closure, or craniectomy definitely has a more risk of the pseudomeningoceles or CSF leak. So prefer to do craniotomy and replace the bone flap, and here the watertight dural closure with fascia or dural substitutes can be done along with the enforcement by glue. And and one more important thing is, whenever pseudomeningocele or CSF leak is there, we have to exclude the presence of raised ICP. And most of the times, if the raised ICP has been taken care, this will pseudomeningocele will.
We have to conclude. We have running out of time.
Yes, sir. So next is CSF infections are more, there is more risk because of the steroids or CSF leak. Then the endocrine dysfunctions occur usually because of the adjuvant therapies. So I'll just skip this is a checklist what we have to see in patients with the medulloblastoma early complications. So we have to see the prior medical behavioral, are there any prior medical behavioral issues? Then airway, breathing, circulation, temperature always has to be checked. Evidence of raised ICP has to be checked for focal neurological deficit. So this checklist can basically cause early detection and then reduce the side effects because of it. So to conclude, we have to identify preoperative baseline risk in each child for occurrence of surgical complications. A multidisciplinary neuro-oncology assessment prior to resective therapy is required, including appropriate neuroradiology and oncology involvement to identify the goal and extent of resection. CSF diversion procedure should be considered to reduce many complications which can be exacerbated by hydrocephalus. And preoperative planning, surgery, and adopting T-Lovella approach, avoiding too much of traction, can reduce risk of posterior fossa syndrome. And checklist for early detection of complications in perioperative care should be implemented. So, shall I just show a few important points in adjuvant, or it is some
we'll stop here, Dr. Vishaka. I think it was a good presentation.
Okay, so yeah.
One thing is, it's going beyond almost 9 o'clock, so I think we should wind up.
Yes, sir.
Thanks for the presentation, and I thank all, the panelists and all the presenters for an interactive session. And this is an important and day-to-day topic. We should know about the pathology, and we should know about the various treatment options, as well as we should know about the complications that we encounter, and how it's not like one size fits all. There's no single answer for every complication. This needs to be customized and personalized in each individual care. Any comments from Dr. Rupesh? And then
yeah. So overall, I think it was a nice cases discussion. Madam also good. Finally concluded what are the complications. One important point is that medulloblastoma, we should try to do good surgery, because suppose these CSF leaks and inadequate dural closure can prolong it can delay the adjuvant therapy, because as we know, adjuvant therapy is very important, and any factor which delays like a pseudomeningocele, especially the pseudomeningocele. So one point again in discussion, whether ETV versus a VP shunt, whichever has a quickest rate of remedy for pseudomeningocele, I think we should adapt that. ETV may or may not prevent a pseudomeningocele, whereas a VP shunt can do. So if a child has to go for a quick adjuvant therapy, I think a VP shunt may be a better option than ETV, so that the adjuvant therapy can be completed, the CSF leak, the pseudomeningocele all can come down. The other important factor is a lot of discussion now. I think the recent guidelines shows we were all surgeons thinking about very less residual tumor, and then a gross total excision is very good. But after the molecular subgroups have come, I think you see the oncologists are not no more stressing the fact. I think Dr. Ricky is here. She may also fact. I think for the group 4 is the only group where they say safe maximum tumor resection is good. Whereas in other tumors, as we considered the residual tumor more than 1.5, that really doesn't matter. In the recent oncology discussions, Madam can show some light on that. And one important factor is the residual tumor. Why we should chase the residual tumor is that the risk of post-op hematoma is quite high. So unless we remove the tumor, the residual tumor is the one which causes the bleed. So for that reason, I think we should go ahead. The tumor, maybe probably the tumor which is attached to the floor of the fourth ventricle, especially around the 6th, 7th nucleus and the lower cranial nucleus, I think it's better to leave behind that, and the rest of the tumors is better to remove safe maximal way. So Dr. Ricky, can you just comment on the fact that as neurosurgeons we stress on a safe maximal resection, but as oncologists, other groups 1, 2, and 3, you may not stress us on the safe maximal resection.
I'm not sure.
Ricky is, I think, not there. So I think, yeah.
I'm not sure Dr. Ricky is there. They left.
Yeah.
Yeah. Okay. Thanks, Rupesh, for those comments. I think with that, we'll come to the end of the session. I thank DigiNeuro, our host, for this program, and this is available in the website. And on behalf of IndusPain, I thank the speakers, panelists, and chairpersons for this program. And thank you. That's all for today. I think 1 minute. Dr. Deepak Gupta, you are there?
Yeah, I'm there.
Yeah.
Yeah.
Yeah. Your closing
No,
remarks.
I just want to thank everybody, all the speakers, especially speakers from the Amrita Institute of Medical Sciences and Shri Chitra for putting up very good cases. And I think we had a very good discussion on medulloblastoma, and all the speakers were excellent. So with this, I think we want to thank everybody who joined for this webinar. And also, we would like to invite everybody for the forthcoming annual conference of Indian Society for Pediatric Neurosurgery, which is scheduled between 23rd to 25th of January. The meeting will be held at AIIMS Rishikesh. I hope many of you who are online will be able to join.